My name is Simon Yu. I'm one of the dermatologists here at Northwestern. I'm also a Mohs surgeon. And I'm tasked today with talking about the surgical treatment of melanoma, specifically resection and repair. I have no relevant financial disclosures. The first step in the treatment of melanoma and the treatment that confers the highest cure rate is surgical excision. The amount of skin around a melanoma that's excised is called the margin. Advances over the past several decades have reduced the amount of tissue needed for high cure rates, and now smaller margins can be taken. Really from 2 to 5 centimeters a decade or more ago to 0.5 to 2 centimeters today. Overall, the margin taken around a melanoma is determined by how deep the melanoma is, not how wide it is. This is determined by the Breslow depth. The depth of the margin taken is into fat for in situ or Lentigo Maligna melanomas, and to the fascia for anything deeper. This is just a simplified table of the tumor thickness versus the clinical margin taken. Really anything at 0.76 millimeters of Breslow depth, or even thinner lesions that have other risk factors, such as ulceration or mitoses, a sentinel lymph node biopsy should be considered in that situation. And my colleague, Dr. Wayne, who you've already met, will be talking about specifically the sentinel lymph node biopsy after me. In general, the length of the scar from a melanoma resection should be about 3 to 4 times in length the diameter of the lesion plus the margin taken. It's better to have a longer scar that lies flat versus a shorter scar that is puckered. In most cases, this principle applies to melanoma excisions, particularly off the face. So people ask me how long the scar is going to be and why an excision is so long. It's because of this principle. It's basically geometry that the length of the scar has to be 3 to 4 times the lesion plus the margin taken, or else the scar will pucker. I'm going to talk a little bit about Mohs surgery here and how it applies to melanoma. Mohs surgery was developed by a gentleman, Frederick Mohs, who's a general surgeon, in the late 30s. And he developed a technique to remove basal cell and squamous cell skin cancers that produced a higher cure rate than previously. The technique is really predicated on looking at 100% of the edge of the skin cancer that is removed, by not having to guess where the edge of a skin cancer is. The Mohs surgery allows for the highest cure rate while leaving the smallest defect, which can produce the smallest scar possible. In general, Mohs surgery is not required for melanoma. Most melanomas are pigmented, so the edge of the cancer is usually obvious, and the margin can be easily determined. And most melanomas are not found in the face, where tissue-sparing techniques are the most valuable. However, there are probably 2 exceptions in my mind where Mohs surgery, or in this situation, slow Mohs surgery, can be used. That is for Lentigo Maligna, which is a form of melanoma in situ on the face, where tissue sparing is a priority. And then also we've used it in Northwestern for melanoma in the setting of severely sun-damaged skin off the face. So Lentigo Maligna is a form of melanoma in situ that progresses very, very slowly and can remain in a non-invasive form for years. It's mostly commonly seen in older patients with a peak incidence in the 9th decade. It's usually found on skin areas with high levels of sun exposure, like the face and sometimes the arms. Melanoma in sun-damaged skin. Margins for a melanoma arising in a mole is relatively straightforward, like the photo above. It's pretty obvious where the margin should be taken in that situation. But for a melanoma arising in chronically sun-damaged skin, it may be really difficult to assess for the pathologist where the margin is, if the margin is clear, because there can be several atypical cells on that margin. So Mohs surgery or slow Mohs may have some utility in that situation. I'm going to move on to reconstruction now. So most melanoma reconstruction is done immediately after the melanoma is excised with a margin and results in a linear scar. Melanoma excised with slow Mohs surgery on the face may result in a delayed closure and involve flaps and grafts. The next couple of slides may be a little graphic, not in the Kim Kardashian sense, but in more of a physical sense. So this is a patient that we had recently that had slow Mohs surgery for a Lentigo Maligna, and we kept taking stages until the Lentigo Maligna was cleared. This is after clearing of the melanoma in the middle of the reconstruction, and this is immediately after the sutures were put in and a drain was placed. And this is him about 6 weeks after the surgery. So he went from a relatively large defect on his cheek, temple area, to a reasonable cosmetic result. And the last thing I want to talk about is scar improvement. And this is one area in terms of surgery where technologies have progressed tremendously in terms of improving scars after skin cancer surgery. I'm going to give 2 examples of how lasers have really improved aesthetic results after surgery. This is the pulse dye laser. This is from a scar, not from a skin cancer patient, but it's a traumatic scar on a young person's face. But this is a very good example of what the pulse dye laser can do after incisional or excisional surgery. And this is another traumatic scar, but this is after about 3 treatments of a fractionated erbium laser that we use often after skin cancer surgery. So in summary, most melanomas are curable with wide local resection, resulting in a linear scar. A minority of melanomas may benefit from slow Mohs surgery. Those melanomas on the face may require a flap or graft reconstruction, and technological advances with lasers have greatly improved the aesthetic outcome of post-surgical scars. Thank you.